Hello, everyone. You're welcome to yet another edition of the Researchers Forum platform. And thank you all once again for being a part of this great initiative. This is a platform that is dedicated to researchers, mainly for them to share ideas, to facilitate knowledge transfer, foster collaboration, and support publishing opportunities. If you have joined us here today and you've not shared your details in the chat box, kindly utilize the chat box, share your name, your country, and your institution. And you're all once again welcome to this edition of the forum. And just to say that this event is being live streamed on the YouTube and Facebook platforms of the Association of African Universities. The Researchers Forum is jointly led by the Association of African Universities, AAU, Afrobarometer, and Taylor and Francis Group. Kindly scan the QR code on your screen from time to time just to access the program. And now, for those of you who participated 2 weeks ago, that is the launch of this forum, we had a very powerful kickoff session that was focused on agriculture, specifically on leveraging indigenous knowledge and innovation for sustainable livelihoods in Africa. We had two presenters, one from the University of Namibia and another from the International University of Management. And in today's session, we are focusing on health, specifically on the theme, Advancing Public Health Resilience in Africa, Leveraging Research, Surveillance, and Innovation. We have two presenters joining us here today from Kilimanjaro Christian University in Tanzania and the University of Ilorin in Nigeria. My name is Lydia Nyame, and I'm going to be your moderator for the Researchers Forum. You're all welcome to this forum once again. And now to our very first presenter. She's in the person of Dr. Cecilia Charles. She's a medical doctor and public health researcher serving at the Hospital Research Study Coordinator. She's serving as the Hospital Research Study Coordinator at the Kativi Regional Referral Hospital in Tanzania. She holds a master's of public health and a bachelor's degree in medicine, and she brings 5 years of experience in both qualitative and quantitative research. Her work focuses on infection prevention and control, antimicrobial stewardship, and adolescents' sexual and reproductive health. Her research investigates compliance with infection prevention and control practices and the factors influencing adherence among healthcare workers at Katavi Regional Referral Hospital. The study was motivated by the high rate of hospital-acquired infections and antimicrobial resistance challenges that continue to threaten patient and worker safety in resource-limited setting. Please help me welcome Dr. Cecilia Charles as she presents. So we are sharing your screen, Doc. If you are available, kindly unmute for us. So over to you. Kindly proceed. You have 30 minutes for this presentation. Thank you very much.
Okay, thank you everyone for joining this platform and listening to me for presentation. My name, as I've been introduced, I'm Dr. Cecilia Charles. I'm the research scientist and currently working on the infectious diseases. I'm here to take you through my research work that I've been working recently. This titled Compliance with Infection Prevention and Control Practices and Associated Factors Among Healthcare Workers in Tanzania. This is an experience from a secondary level regional referral hospital. That's Katavi Referral Regional Hospital. Okay. Proceed. The outline for this presentation, we shall have the definition of terms, background, problem statement, methodology, results, discussion, as well as the conclusion and recommendation. The key definitions in this presentation, we shall have two key definitions, that is compliance and infection prevention and control. Compliance to this study, it's referred as the process by which healthcare workers follow the established guidelines, protocols, standards, and policies to ensure the patient safety, infection control, ethical practices, and legal regulation within the healthcare setting. This according to CDC 2024. At the infection prevention control, This generally refers to the activities that are designed to prevent the transmission of organisms from the patient and the staff to prevent the healthcare-associated infection. Globally, every year more than 3 million healthcare workers are being exposed to blood-borne pathogens due to poor IPC practices. And the research, previous researchers have documented that 28.6% of all hospital-acquired sepsis are due to hospital-acquired infections. And there's annual increase of hospital-acquired infection to about 0.06%, with the incidence of 2 to 10 times higher in low and middle income countries compared to higher in middle income countries. Also, in every 100 patients, 7 from high income countries and 15 from low and middle income countries are expected to acquire the hospital-acquired infection, at least 1 during their hospital stay. And at least 1 over 10 will die from those hospital-acquired infections. And the burden is highly increasing in the African continent, where the prevalence of hospital-acquired infection is about 12.9%. And in East Africa, carries the highest burden it has the high share to this burden of the problem, where it constitutes of 19.7%. In Tanzania particularly, there is 14.8%. So where does this hospital-acquired infections occur? The usual common found around the patient environment is where the healthcare workers interact with the patient. For example, to the wheelchairs, where the patient, the healthcare worker carry the patient to either investigation or to any other services during the hospital stay. But also to the investigation tools, for example, the ECG machine, the hospital beds, the toilet, the locks of the door, etc. These are examples where the high sources are commonly found. Now then, due to these sources of the hospital-acquired infections with the burden, what is the impact of the poor IPC practices? When we have the poor IPC practices, the common problem, the first, is hospital-acquired infection. But before that happens, even the healthcare workers themselves, they do get these side effects. For example, due to needle stick injury, a healthcare worker may get the mental disorder like anxiety, depression, worrying about being infected or not. But also, when the patient or healthcare worker gets hospital-acquired infection, there's high chances of getting death due to because this infection, and so they may end up with deaths. And it's projected that nearly about 3.5 million people are expected to lose their lives due to hospital-acquired infection. All that's when they are happening, even there's lost productivity in the country. For example, the GDP loss resulting from the permanent loss of work productivity due to death from AMR infections have been increasing due to poor IPC practice, which have been resulting to AMR and the hospital-acquired infection. But also, with the loss of reproductivity, economic status of the country, economic burden resulting to the family and the healthcare system due to high consumption of using high expenses in combating AMR or treating hospital-acquired infection, and so generally leads to these negative effects. Now then, IPC intervention have been proven to reduce at least more than 70% of these hospital-acquired infections. And some researchers previously have documented that the availability of the IPC committee in service IPC training, availability of IPC policies, adequate knowledge of using PPEs, working experiences, availability of IPC supplies and safe waste disposal and segregations were the factors that were associated with the compliance. However, researchers and different researchers from different geographical locations have been proving that variation of these factors depending on those variation of the geographical. Now, with what have been documented on factors and up to date, what has been done to the country in order to combat the hospital-acquired infection is establishment of the IPC documents since 2004. But also, since establishment, hospital-acquired infection have been increasing. And so in 2018, there was revision of this national IPC document so as to align with WHO and see where there is the gap so as to to reduce this burden of hospital-acquired infection. Despite of this ongoing effort to disseminate the IPC guideline, training healthcare workers, and to monitor the execution of IPC guideline, still there is loss of, there is still a growing burden of hospital-acquired infection across facility levels and from the primary, secondary, and tertiary. So, the gap has been observed that components of the IPC practices, that's including PPE use, prevention of cross-infection, hand hygiene, waste disposals, see the practices are still low. And thus, due to that, it is that so high mortality, high hospital-acquired infection, and thus it leads to slowing down the efforts of executing the Standard Development Goal 3.8 that aims to ensure the coverage of the universal health coverage. So with that, we still see that there's still a long way to go so as to reach this Sustainable Development Goal 3.8, which is near soon of 2030. With that background, we came to establish the problem statement that the hospital-acquired infection is still a problem, despite of dissemination of the IPC guide and all that the country has been done. Still, we're still far from reaching the health coverage of, reaching attainment of Sustainable Development Goal of 3.8. So with that, we came to establish the study in order to find what are these factors beyond what we have been knowing that are contributing to, poor IPC, which is a bridge for reducing the hospital-acquired infection. And the rationale of this study is that the study was expected to address factors that are associated with IPC compliance so as to generate the best clinical practice culture among healthcare workers, but also to help the hospital administration to establish the focused intervention that is aimed to address the poor compliance and its consequence, but also to help the policymakers to strengthen the resilient health systems at healthcare facilities by enhancing preparedness and responses to ensure unexpected infectious disease outbreak. But also, the finding of these studies are expected to be the baseline for the policy formulation and future studies. Continue. We have the general objective that is to evaluate the level of compliance. The first objective is to determine the level of compliance of IPC practices among healthcare workers. And second objective was to determine the factors associated with the IPC compliances among healthcare workers at Katavi Referral Regional Hospital. The methodology, we used the analytical cross-sectional study design, and study area was Katavi Referral Regional Hospital. Duration was between June and July. Yes, and we used the Kish-Leslie formula, where we obtained the sample size of 419. But because the population of the healthcare workers, all who are found to work at Katavi Referral Regional Hospital, the population was 366. Therefore, we use the proportion formula to find the proportion of the sample size. And there we had the final sample size of 195. And the distribution of this was depending on the categories. We had the categories of doctors, nurses, and laboratory technicians. So registered number of the doctors to the hospital was 83. When we use the adjusted formula, the proportional formula, with at the final, we had the sample size of doctor that was 44, and nurses, the registered number was 252. After calculating with the proportional formula, we had the final sample size of the nurses, which it was 134. And because they had the big share, I mean, they had the big number. That's why it came 134. Laboratory technicians who are registered, who are permanently working at the hospital are 31. After having the calculation using the proportional formula, there were 17. So the total number of the sample size that was used in this study, it was 195. The sampling technique, we use the stratified sampling to select the group of doctors, nurses, lab practitioners, and then from the strata, we use the simple random sampling to select the individual participant. These groups we selected purposely because they are the groups who are mostly in touch with the patient. So we thought, having these groups, we shall have more the lived experiences, and the results maybe they could be used later to have them, to give us what to modify later on. So the study variables, dependent variable was the compliance, where we used the Likert scale, and the interpreted variable, it was the other factors like social demographic characteristics, working experiences, years of working experiences, history of needle stick injury, hepatitis B vaccination, supportive supervision, IPC training, IPC motivation at the working place, availability of IPC supplies, and presence of IPC committee. Data collection tools, we use the validated questionnaire that was developed by the WHO, and also we use the observation chart. Data analysis, this was, we used the starter version 15, and where we had the descriptive statistics, categorical variables were presented in frequency and percentage, and the numerical variables were mean and standard deviation. We also performed the inferential statistics, where we did the modified Poisson regression to find the factors associated with IPC compliance. And the factors were statistically significant at the p-value of 0.05 at confidence interval of 95%. This research obtained the ethical clearance from the Institution Review Board, IRB, of the Medical Research and Ethics Committee from Mbeya in Tanzania, and the permission for data collection was also obtained from the Research and Publication Department at Katavi Regional Hospital. Written consents were also obtained from the participant, and the privacy and confidentiality were ensured, where we used the ID numbers instead of names during data collection. So the results, we had the demographic characteristics of these healthcare workers who were the main participants in this study. Mostly were between the ages of 18 and 30, where we had the 49.7%, and majority of them were male, who had 57.9%, and most participants were nurses, where we had 69.2%, and majority of them had a diploma level of education, about 47.7%. And most of the participants had a working experience of between 2 and 5 years, and they are the larger group of 44.1%. Continue. Okay. In obtaining the level of the IPC compliance, we use the Likert scale to determine the IPC practices. And this was the WHO tool that had 20 items. And among these 20 items, 4 were negatively stated, while the rest were positively stated. So for the participant who had who got it correctly was scored as 1, and participant who had who got it wrong was scored as 0. With that, the total, the summation of these 16 over 20 and above were regarded the high compliance, while below that, below 16 over 20, which is equivalent of 80%, were regarded as the low compliance. So the items that were used to evaluate the IPC compliances were categorized also depending on the main theme. For example, the use of the protective device. These were the items. And you see that majority of the healthcare workers, about 59.5%, they reported that only 59.5%, they reported that they wear surgical mask alone or in combination with goggles, face mask, and the apron whenever there is possibility of splash or splatter. While the rest, they reported that they did not wear. So this was among the items that scored poorly. While the other, for example, about 88.2% of all healthcare workers, they reported that they usually wear the gloves whenever they're exposed to the blood fluids, blood fluids, and any excretion of the patient. And this is actually showing the promising because it was scored highly. On the area of the disposal of the sharps, only 35.9%. They were aware that the sharp box is only disposed when it is full. So the rest, they were not aware. They just reported that the sharp box is only disposed when it's full. So only 35.9%, they are the ones who know that it is incorrect for the sharp box to be disposed when it's full. The rest of the items, they had the moderate performance. So this, the one that had well performed. Let's continue. Also, to the prevention of the cross-infection, only 46.2%, they reported that they do take shower in case of extensive splashing, even after they have put on PPE, while the rest, they reported that they did not do that. So that signifies that to this item, 46% is the low number who reported that this component is doing well. The rest, they don't do that. So they don't do this this item of IPC in an appropriate way. Let's continue. Overall compliance, with that 20 items that were individually evaluated, the overall compliance, it was found that 61%, they had non-compliance or low compliance. That means that they scored the less than 80% of overall compliance, while only 39%, they had good compliance. And this benchmark of 80%, it was according to the guidelines from the Ministry of Health. And thus, this is to say that majority of these healthcare workers, they had poor performance. Let's continue. With the factors associated with the IPC compliance among healthcare workers, it was found that the profession of healthcare worker was associated with the IPC compliance. And we see that doctors, all clinicians had 0.32, or the lower chances of performing IPC practice compared to the nurses. And this was statistically significant. But also the healthcare workers who were exposed to the blood or body fluids had higher chances of complying with the IPC compliance compared to those who are not exposed to the blood fluids. So this factor was also statistically significant. Let's continue. The healthcare workers who were motivated during the workplace, more than 40% higher chances of complying with the IPCs compared to those who are not motivated. And this factor was also statistically significant, while the IPC supportive supervision that was performed annually showed having more chances of complying with the IPC compared to those healthcare workers who had no supportive supervision at any period in a year. But also, the healthcare workers who confirmed the IPC committee, the presence of IPC committee, showed the high chances of complying with the IPC compared to those who had no the IPC committee. And these factors, all they were statistically significant. We also use the observation checklist to determine the supplies of these IPC materials in the working areas of the healthcare workers, and where we found that of all 9 wards where the healthcare workers were performing their duties, there was the deficiency of soap and water in latrine, about 55.6 and 44.4% across all wards, while the rest of the items were present. For example, the waste management items like color-coded bins, functional autoclaves, face masks, PPEs, and injection safety, they are all in a place. So in discussion, we may say that the overall compliance with the IPC practices among healthcare workers was 68.9. That was overall. And this finding was similar with the other literatures. For example, River State in Nigeria, that found 59%, Rwanda 64.5%, Lesotho 63.6%, Ethiopia, and some parts of Tanzania like Songwe region where the compliance was found 66.6%, and St. Francis Different Regional Hospital in Tanzania, where the compliance, the overall was 54%. In contrast, the other countries, for example, Iran, Bangladesh, Ghana, and Nigeria, also the compliance were more low compliance compared to the findings of our study. So the general implication of this observation is that there is urgent need for policymakers, management team, and healthcare workers to strengthen strategy that promotes implementation of this IPC, because it seems it's a global problem. But also, 40% of healthcare workers, as we saw to the components of the IPC, they do not wear the surgical mask in combination with the face shield and apron whenever there's risk of splash. And we saw that nearly 70% of all healthcare workers, they rely on water alone for hand washing, despite of availability of the items that were approved to the checklist. So similar findings were found in Ethiopia, Uganda, and in India, where the poor PPE use and inadequate hand hygiene were linked with the inconsistent PPE supply, discomfort, and perceived low risk. Contrary to this finding, Brown et al. In Kenya found that healthcare workers followed IPC practices by wearing the full PPEs due to ongoing IPC training and the strict supervisory checklist. The difference of these studies is because this study was done during the COVID-19 era, and so where there was IPC training and strict supervisory checks, and it could be resulted these differences in findings. Implication, it is that all these results, they underscore the urgent need for strengthening supply chain management, ensuring consistent availability of PPEs, IPC resource, and strict enforcement of IPC protocols in all health facilities. In factors that were associated with the IPC compliance, we saw that the professional level was associated with compliance practices, IPC compliances, where we saw that the doctors showed low compliance compared to nurses. Similar findings were found in United Kingdom, Bangladesh, Australia, and the Songwe region. The possible explanation for this observation could be due to the inclusion of the additional IPC courses in nurses training programs during their schooling, or either could be the shortage of doctors that is resulting to excessive workload and the corresponding decline in participation in service IPC courses. So all these results, they reflect that there is need of targeted IPC education training among healthcare workers, irrespective of the cadre, and workload management strategies that bridges the gap, the compliance gap, and improve the outcome at KRH and the similar setting. The other factor was found that healthcare workers who were exposed to the body fluids showed a higher compliances compared to those who have no exposure. And similar findings were found in Ethiopia study, but also in Ghana, there was contrary finding where there was found that there was no association. And still this finding underscored the need for the importance of strengthening risk perception through the CME, continuous medical education and awareness among healthcare workers. But also these findings, it serves as the call to action for Katavi Referral Regional Hospital and similar setting to reinforce compliance with the IPC practices, even in absence with the immediate exposure risk. Also, IPC training, this showed those healthcare workers who had who received IPC training showed high IPC compliance versus those who did not attend this training. And this reflects that the knowledge cascaded from those who are trained from the Ministry of Health to their colleagues and then disseminated. It reflects a kind of peer learning model that has been reported by other researchers to increase the reach and the sustainability of the IPC practices in a rural resources setting. Also, the results showed that the healthcare workers who were motivated during the workplace showed high compliance levels compared to those who had no motivation. The similar findings was found in qualitative findings that was conducted in similar setting. And so where the healthcare workers explain that they feel energized when they are motivated and recognized publicly after performing well. But also Hongton et al. Reported that self-motivation among healthcare workers by perceiving IPC value of protecting themselves, their families, and their patients is a behavioral change motive that toward IPC compliance. And so it implies that intervention that involves self-motivating, including giving incentive, even if it's non-monetary, and the recognition can significantly influence the IPC compliance among healthcare workers in Katavi Referral Regional Hospital or any other similar setting. Also, supportive supervision was the other factor that was found, that was identified in this study to be significantly associated with the IPC practices. And from this observation, it's from the basis of the current study, where the healthcare workers who received the IPC supportive supervision showed more to comply with the IPC compliance compared to those who are not supervised at any time in a given year. Other researchers, they also reported that, for example, in Gambia, they also reported that healthcare workers who had supportive supervision they are more likely to show high adherence to this IPC guideline. And so it implies that a continuous and thorough monitoring system for IPC practices among healthcare workers is the backbone and therefore should be strengthened and maintained. To the hospital, the IPC committee, if the healthcare workers know that there is IPC committee, mean that they'll be able to what the IPC committee have been doing, the activities that this committee have been implementing. So far, the IPC is concerned. So the observation, healthcare workers who confirmed there is the presence of IPC committee showed high compliance with the IPC practices. And a similar observation, it was done across the health facility in the Kampala region during the COVID-19 era, where the findings emphasize that for the healthcare workers to comply with the IPC practices, there was need of IPC committee activities and work plans to be supported by the budget lines. Also, this reflects that IPC committee at Katavi Referral Regional Health Hospital is a factor that influences healthcare workers' compliance to adhere with the IPC practices through its initiatives such as routine monitoring and providing feedback on the IPC strategy, as well as the provision of a reminder on the IPC activities.
Hello, Doc. Can you kindly wrap up? We are way behind time, please. Thank you very much.
Thank you. Okay. Strength and limitation of this study is that this study, it sheds the light to the necessity motivating of healthcare workers regarding the regular IPC training, strengthening IPC supportive supervision activities, and the IPC committee coordination in the hospital to enhance overall compliance levels. But also this study identifies several key findings that need further researches with a larger sample size, and also robust design, for example, the longitudinal study and the direct observation to ensure the real, rather than self-reporting, to ensure the real compliance on daily observation on how healthcare workers are being performing the IPC during their routine work. But also this results, they serve as the baseline information for the related studies in our area and similar contexts. Next. Limitation for this study is that it was self-reported, but also there is possibility of recalling bias. And because it was a cross-sectional study, we failed to have the causal inferences, but also they missed the healthcare workers who were absent during the survey time. We missed these people, and probably due to they could have given us much more information as they have, they have attained this occupational conclusion. The study concludes that the overall compliance among healthcare workers was suboptimal. Well, we found that the overall was 68.9, but the 39% of all healthcare workers had high compliance, while 61 had low compliance. And factors for IPC compliance was supportive supervision, workplace motivation, presence of functional IPC committee. Identified gaps in wash infrastructure, particularly inconsistent availability of water and soap in latrine, may further concern compliance with the IPC practices. And so we recommend that given the high burden of hospital-acquired infection and AMR, further studies should be carried out in a longitudinal study design involving multiple healthcare settings to validate this association and better inform the national level IPC policy and implement strategies. And so this is the end of the presentation. Thank you.
Thank you very much, Doc, for this very insightful presentation. We are very glad to have you on this forum. Thank you once again. I just have a few questions, and I see that a number of our participants have also posted some questions in the chat box. So perhaps I'll just ask my very first question, then I would read a few of the questions in the chat box. But if you are here with us and you want to ask a question by yourself, kindly feel free to raise your hand and we'll help unmute you to ask your question. So Doc, my very first question So your study found that IPC compliance remains suboptimal despite policies and training. So what I want to know is that what are some of the most critical system level gaps that continue to limit compliance in practice, particularly in resource constrained settings? Thank you very much. Over to you.
Thank you for the question. Can I answer now or should I wait for?
No, please, you can answer. Please proceed.
Okay, thank you. From the study observation, I found that regarding on the factors that have been found to this study, there's additional thing that I came to realize using the observation checklist. Most of these factors, they are also depending on the availability of the resources. For example, the factor that found that the healthcare workers were not washing their hands. Not that they didn't know, they reported that they don't wash their hands. And also we counter check later on using the observation checklist, and we found that there is no water in the latrine, there is no soap. And so maybe figuring out both factors, supplies and knowledge on what IPCs practice at the health facilities, counteracting those effects both at supplies level and also at the level of the healthcare worker themselves, they could bring much effect on the IPC compliance.
All right, thank you very much, Doc. So I'm going to start off by reading the very first question here. So this question says, are there any policies in Tanzania that focus on the reduction and management hospital-acquired infections? This is from John from the University of Namibia. So Doc, over to you.
Yes. IPC combating high hospital-acquired infection is managed in multiple ways. There's a lot of the army efforts that are aiming to combat the hospital-acquired infection, and the IPC is one of them. There are more other efforts like antimicrobial stewardship team, focusing on the AMR, antimicrobial resistance, but also there is this wash and so on. So IPC is one of the efforts. And now narrowing down to the IPC activities that have been routine practiced, apart from seeing what the healthcare workers are doing underground, there are those like training quarterly or at some period, but also dissemination of these guidelines regularly and all that. They have been updated over and over, like I said, from 2004 to 2008, and so other efforts that have been doing. But also there's regular follow-up from the Ministry of Health to the health facilities. They give the they come to supervise at least in a quarter or semi-annual to meet to do the overall IPC performance across the facilities. Now, going down to what the individuals are doing, it's now to the part of the hospital administration to take what is required to what is recommended by the Ministry of Health to disseminate to the individual level. Now the gaps come there. That's even what has been provided, the healthcare workers don't take it into consideration to actively do what is required. And so, and because the lower level facilities, for example, this is the regional, mini regional referral hospital, the secondary level, there are lots that have been done, and without an extra eye to have the self evaluation to see how our healthcare workers are doing these things underground, it's very unlikely for the Ministry of Health to recognize what's the problem exactly. So that's why we came with this study, so that to have the internal efforts ourselves, but also to give the result to the Ministry of Health so that they can see what they can do in order to boost up these IPC performances.
Great. Thank you very much, Doc. Doc, I think it would really be great if you could turn on your camera. I'm pretty sure everyone here would really love to see you in person. So if you can please turn on your camera as I read the next question that we have here. So the question says, is there any opportunity to witness the application of IPC in addition to the questionnaire? I think watching the healthcare professionals in real time would add a lot. What's your opinion in terms of the challenges? This is coming from Aboke Salah. Please pardon me if I did not pronounce your name well, but Doc, over to you. Yeah, so let me take the question again. This question says, is there any opportunity to witness the application of IPC in addition to the questionnaire?
I would have said that in addition to questionnaire, we can do the direct observation, if I have get it to you clearly, that to see, because the questionnaire itself, we assess the individual on what they are reporting. So we recommended later, if we could have the direct observation, for example, as we assess the hand hygiene, for example, how these healthcare workers report that they do wash their hands. If we could use the other tool of hand hygiene, like observing those 5 moments of hand hygiene, maybe it could give us the other results that we could have made the decision on that. If that's what she meant.
Okay. All right, that's fine. I see someone's hands up. Okay, I think the hand is down. So maybe let me just read the last question. Then I'll hand over to our partner from Afrobarometer who would share some insights. Okay, I see your hand up. So Amiable, please unmute and come up with your question.
Hello, everyone. Are you getting me?
Yes, we can hear you loud and clear.
Okay, I'm Amiable Sibomana. I'm normally a student, PhD student at University of Burundi, but actually I'm working in the Public Health Emergency Operations Center of Department for Ministry of Health in Burundi.
Okay.
So I just have one question in terms of systemic approach. I'd like to know, how can IPC be effectively integrated into the epidemiological surveillance system, including preparedness and response, in order to reduce the risk of nosocomial and community transmission during outbreaks?
Thank you for a nice question. IPC, as I've said, that the IPC is an integral part, the key components in healthcare delivery. So if the IPC is routinely done as it's required, more than 70% of these hospital-acquired infection, including this outbreak and all that, bloodborne diseases and all that, could be prevented. That's according to the researchers. And so we saw that from the observation in comparable studies, most of the IPCs were performed well during the COVID-19 era. And to that, due to strict supervision and adhering to what is required, the IPC performance, it was really well done. And so we reflected that if that could be the case over the years, even in absence of the outbreak, it was possible to prevent these the outbreaks and other hospital-acquired infection, even without the outbreak. And possibly it could reduce the rates of this outbreak in some instances, because the IPCs it's focused on preventing the infection from the patient as well as the healthcare workers. So it could cut off the transmission. So that's saying that IPC is very important, and we need to get prepared even before the outbreaks happen. Thank you.
Thank you very much,
Thank
Doc.
you very much for the answers.
Thank you for the question as well, Amiable. So maybe the last question, then I'll hand over to Kamal. So this one says, which factors in terms of training, resources, workload, attitudes were mostly associated with compliance and non-compliance levels? This is coming from Paul Mulala. So Doc, over to you.
From the results, we saw that the factors between all that I projected it out, the factor that shows the highest compliance to the level of the profession. Doctors showed the low compliances compared to nurses. And this factor was statistical significance for less than 0.001. So this significance association, I came out with a plausible explanation to find out why doctors performed poorly IPC compared to nurses. And we found that the IPC was the cause that was taught in the nurses module, but also the rate of the population of nurses to the healthcare to the health facilities in Tanzania country is higher compared to the other cadres. And to approve that, even to our population in our study, we saw that nurses were more contributing. They were 139 members who were the participants to this study. So with that saying, it was if this training that they are getting as the additional module to their course, it could also be done to the other cadres, for example, doctors, laboratory practitioners. Maybe it could elevate the results and improve the IPC performance. Thank you.
Great. Thank you very much, Doc. So, Kamal, if you are here with us, kindly come in with some insights from your side. Kamal works with Afrobarometer. So, Kamal, over to you.
Thank you, Lydia. Can you hear me?
Yes, you can be heard.
All right. So I would like to just share my screen to share our resources with you. But as we wait for my screen to share, I would like to congratulate Dr. Cecilia. That was a very well done presentation. Can you see my screen, please?
Yes, we can.
All right. Yes, so Dr. Cecilia, that was a very well done presentation. It's a particular area of interest of mine. I'm also in public health research, and the focus on hospital-acquired infections, as well as the healthcare workers, I think is very, very valuable. And also the methods that you used, your stratified sampling and simple sampling. Those are methods that Afrobarometer also uses to collect representative samples across African populations. I think we kind of speak the same language, so that was nice. But so in terms of my input, I won't be able to, I feel like your work is already good. So perhaps I'll show you some of, and use this opportunity to show the colleagues and yourself, some of the Afrobarometer data that we also collect on public health. So if you go to the Afrobarometer website, we have an analyze online tool. This is what we call the ODA. And if you access it, it shows you, without downloading our questionnaire or the data set, it gives you a brief walkthrough of our, data for your own analysis. So this is how the ODA looks like. And, we've had 10 rounds of surveys so far. Actually, maybe I'm rushing. Afrobarometer basically collects citizen level data. So we ask a representative sample of Africans about their attitudes, perceptions, and experiences on the continent. There's a whole range of questions. As I'll show you soon. So we've done 10 rounds of surveys from 1999, and our latest round of survey was done in between 2024 and 2025. We are currently in the field conducting around 11 surveys that will be between 2026 and 2027. So you click on the round 10, and the ODA gives you a way of, you can analyze, you can choose the country that you want to analyze, or you can also select all countries. You can select multiple countries. But in this case, I'll, for example, select Malawi and then click on analyze. And this takes you to the questionnaire itself. As I said earlier on, we have some questions that relate to public health. For example, we have for the round 10 survey, we had a question on COVID-19. So asking people their perception of the main country or organization contributing for their country to solve COVID-19. However, for the purposes of this paper, I would like to refer you to the problems, given that we are talking about clinics and hospitals and hospital-acquired infections. We also have questions asking people their problems, their experiences with the clinic when they attended the clinic. So Dr. Cecilia, you could perhaps maybe in a different study triangulate your healthcare worker data with citizen level experiences about the clinic. So for example, if you click on problems with the clinic, you will see it gives you the questionnaire and it gives you the breakdown of the questionnaire. So the question is, have you encountered any of these problems with the clinic or hospital during the past 12 months? A lack of medicine or other supplies? And this is for the Malawi sample. And as you can see in Malawi, the majority of Malawians, that we sampled said that they often encounter problems of lack of medicine in the hospital. So this kind of data, so this is just one example of a question. So I would encourage you, Dr. Cecilia, and maybe anybody else interested in public health to have a look at our data. So this is a different module. So I'll just go back. So the problems, we have data on health. So I'll just encourage you to go to our online data analysis tool and have a look at some of the questions that we have. We have a nice module on health. And also one last thing before I leave, we recently used the data that we collected on health to publish what we call a Pan-African profile policy paper. So using the data on health, I'll share the link to this article in the chat, for your perusal. Thank you, Lydia. Over to you.
Thank you very much, Kamal. I think, Cecilia, at this point, I can give you the chance to ask Kamal one question if you have anything that you want to ask him now, since you have him here on the call. So over to you. Otherwise, we'll move on to the next speaker.
Thank you very much. I have no question, but I'm grateful for the opportunity to share with you my work. And I look forward again to see how other members have been doing to the area of the public health in other areas of the concern. Thank you.
Thank you very much. There's a question here for you, Kamal, a question from Duke Afrane. He says, oh, great, you've already responded. So the question says, to Afrobarometer, do you collect data on other variables apart from health? And Kamal says, yes, we collect data on select themes. Thank you very much, Kamal. So we now move to our second presenter. And not only is he an accomplished researcher, Professor Olatunji Matthew Kolawole is a leading virologist, environmental health scientist, and global authority in water waste-based epidemiology. He has previously served as head of department of the microbiology and as a pioneer director of the Institute of Molecular Sciences and Biotechnology at the University of Ilorin. Professor Kolawole is an internationally recognized global exceptional talent endorsed by the Royal Society. He is a fellow of the Royal Society of Biology, the Royal Society of Public Health, Applied Microbiology International, the Academy of Public Health, the Society of Environmental and Public Health Professionals, the Nigerian Young Academy, and the Africa Academy of Sciences, and he leads the Infectious Diseases and Environmental Health Research Group at the University of Ilorin. And today, Professor Kolawole presents on Rethinking Disease Surveillance in Africa, Bridging Arboviruses, Respiratory Infections, and Environmental Health. We are very pleased to have you with us here on the forum, Professor. You have the floor and you're welcome. Thank you very much.
Thank you very much, Lydia. Thank you, distinguished audience. It's a pleasure to be part of this researchers forum. And I want to really appreciate Association of African Universities for this privilege. I want to speak on rethinking disease surveillance in Africa, bridging arboviruses, respiratory infections, and environmental health. Just as I've been introduced by Lydia, I'm Olatunji Matthew Kolawole. I am the lead of the Infectious Disease and Environmental Health Research Group based at the Department of Microbiology, University of Ilorin in Nigeria. Now, I'm going to take my presentation with this outline. Basically, we want to look at the burden, and then which has to do with disease surveillance context and why it matters in Africa. And then we'll look at the problem itself, the three angles to the problem, the thesis, why viruses, RTIs, and environment are one story. And then the third outline is going to be the diagnostic gap, which of course we're going to look at the problem statement and the unmet needs in Nigeria. And then I'll take you through arboviral and RTI evidence, which has to do with rubella, Zika, dengue, chikungunya, and respiratory viruses. And then I will also take us through environmental intelligence, the rivers, wastewater, metagenomics, and bioflocculants. And building the bridge which has fallen, I must tell you, in Africa, how shared patients, geography, and seasons force integration. And then finally, we'll wrap up with Towards One Health, which has to do with integrated surveillance, the AI tools, and recommendations. Now, the burden and the background, which forms the context in itself, as we rethink on building surveillance in Africa. There's a parallel crisis, and the crisis which every one of us are obviously aware of, or we're not even aware of, but I'd like to bring this to our attention today. First, in sub-Saharan Africa, two epidemics run in parallel and are often confused with one another. First, mosquito-borne arboviral fevers, and second, viral respiratory tract infections in children under 5. Now, both are driven by urbanization, climate variability, poor sanitation, and weakened water infrastructure. Both, of course, remain chronically underdiagnosed at the point of care. Now, statistics have revealed, of course, evidences have been provided that less than 5 years of age children have the highest respiratory infections burden globally. 4 arboviruses, the dengue, Zika, chikungunya, and of course, the related cousin, which is rubella, are co-circulating in the population, not just globally, of course, in Africa continent too. Mosquito-borne arboviruses that have been transmitted through the vectors Aedes and Culex mosquitoes are expanding in range. And that takes us to the point of the problem, which has to do with 3 angles. What are the 3 angles? Arboviruses, respiratory infections, and environmental health are not 3 problems, but they are one problem seen from 3 different angles. And what are the angles? I'd like to show us. Now, it's a case of 1 febrile patient, which are often generally linked in Africa to one river passing through the environment, one river passing through the homes or the locality where they are based. And of course, they're also linked more often than one season. As we know, we have either the rain season or the dry season. Now, in relation to this viral hemorrhagic fever, particularly the arboviruses and respiratory infections, they are all linked to either the environment, which has to do with either the season, and of course, they can also be linked to either the river, which passes around the environment. And of course, we have vectors like mosquito, Aedes, Culex, and vectors,
that is important.
Someone is unmuted, please.
Thank you.
Okay, great. Thank you.
Thank you very much.
Apologies, Prof.
That's okay. Thank you for coordinating well. Thank you. Now, I'd like to show us something which is very interesting, which I want us to all, as much as possible, to sensitize us with the problem in our hands in Africa. We can see from the dengue risk distribution in Africa that virtually all Africa countries are in serious risks of dengue fever, particularly transmission within the continent. That speaks a lot of volume. There is a lot of work ahead of us for us to look into in terms of research. Now, where the work I want to share with us was conducted is in Nigeria. Our study site is in Nigeria, and of course, the sites are 3 northern belt states anchored the human studies, and 3 rivers anchored the environment work. all within one integrated geography. And that geography is where the University of Ilorin, a second-generation university, one of the foremost respected university in Nigeria, where I am based. Our work has been done in the north central of Nigeria, where we have 3 particular locations which have been consistently where we have worked over the last 2 decades: Ilorin, Kefi, and Minna. Now, these are located in north central states of Nigeria. Ilorin is where we carried out the primary febrile cohort investigations. And then in Kefi, we replicated as a study site also, particularly in Nasarawa State. And in Minna, also in Niger State, we also replicated the study. We also went further to juxtapose what plays out in the environment along with the clinical sites. We have been able to establish from our studies also, looking at major rivers that flows from one of the states to other states, particularly from Kwara to Niger, and of course, the suburbs. We have Asa River, Ashipa River, and of course, we also have the Oyun and Agba rivers. We have extensively worked on these rivers that conducted a lot of studies to establish what plays out in terms of public health response and outbreak responses in the northwestern zone, particularly Nigeria, and using it as a scenario for the African continent. Now, the diagnostic gap, and what is the gap? The gap is very, very interesting. It's something that I want every one of us to take note of, is the fact that every febrile child in a Nigerian clinic is still treated by default as malaria. This is not just peculiar to Nigeria alone. Particularly, majority of the African nations treat every febrile children as malaria. And what we miss in that assumption has become a public health emergency in a very slow motion, leading us to a very great chaos. The very surveillance challenges ahead of us is the fact that, one, there are limited molecular diagnostics, which has to do with the real-time qPCR and sequencing capacity, which remains very scarce outside tertiary centers in our nations. 2, the co-infections go unseen. Majorly, most patients that go to the hospital, if they are not treated for malaria or there's no malaria, they say, oh, go back home. Whereas there are other pertinent issues of viral hemorrhagic fever, which are arboviruses, which are very great concerns, particularly with dengue. We have reported dengue malaria co-infections, and other overlaps are rarely screened jointly. 3, environmental drivers have been ignored. And these drivers are very pertinent. I overheard Afrobarometer talking about some of the things they do. And this is one sensitive area which I want us to look into too. We have overlooked the fact of the vector breeding sites, which of course the unsaved water and wastewater pollutions, which are fuel transmissions in our locality, particularly in our continent. 4, data silos prevent early warning. We have had cases of clinical data staying separately from laboratory data, and the environment and the clinics don't speak to each other. Everything works on its own as silos. And at the point we are now, infections, particularly the infectious diseases or pathogens, they actually plays out in relationship with the environment, the clinics, and of course, even with the animal interface. And then our opening here is the fact that seroprevalence, molecular epidemiology, and predictive analysis are now one area of research which are now maturing, which I like to sensitize this audience on what we have done over the years. Now, our research objectives and questions are very straightforward. Primarily, we have developed an integrated data-driven surveillance framework to improve detection, prediction, and management of arboviruses and RTI outbreaks across Nigeria and Africa settings. Our guiding questions are: 1, to what extent do arboviral infections and RTI contribute to febrile illness currently misdiagnosed as malaria or bacterial infection? 2, how do serological results compare with molecular diagnostics, particularly the real-time qPCR, in differentiating active, recent, and past infections, which are very, very pertinent in terms of management of patients in our hospitals? 3, how can integrated database, particularly data sets, I'm talking about the serological, molecular, environmental, and social demographics, improved outbreak detection and prediction? Of course, we must understand that there is a need for us to begin to plan for, future pandemics. And then 4, how genetically diverse are circulating arboviral and respiratory virus strains within regional and global phylogenetic contexts. Our methodology over the years has been an integrated workflow. We had 6 linked stages, 1 data-driven story from the feed to the policy brief. First, we have done extensive study design, cross-sectional and on a targeted cohort by disease objectives. Second, we have extensively done sampling with human samples, clinical specimens with metadata captured. And then 3, we have done extensive screening in these study locations and sites, particularly investigating the IgM and IgG serology for the exposure and active infections. And then 4, we have also emphasized confirmatory assays using molecular techniques, optimized primers that have been designed in our own environment, comparing with primers which are used in other developed nations, detecting, of course, arboviruses and respiratory tract infections. And then 4, we have analyzed phylogenetically risk factors and prevalence, and of course, moving towards the trend of modeling for pandemic preparedness. And then 6, which is one very great highlight which we have been able to establish over the time, is the translation of our findings in terms of surveillance guidance documents for WHO, diagnostic interventions for health settings. Now, the outcome of all this evidence is an evidence-based surveillance recommendations that we have placed for the country Nigeria and of course comparable low resource settings. In other words, it means that we have applied consistently across arboviral, respiratory, and environmental study arms. Now, that takes me to what the clinic data tells us from all our investigations in terms of arboviral respiratory evidence from Ilorin, Kefi, and Mina, which has been our study site over the years. First, in terms of rubella and Zika in women of childbearing age, the invisible risk to maternal health is one very pertinent issue. In our Ilorin cohort of 188 women of childbearing age across 3 northern belts, which I've indicated earlier in my earlier slide, serology revealed widespread poor exposure to rubella and active circulation of Zika, 2 agents with direct consequences for pregnancy outcome. Now, our key results are as follows. First, we reported significant seroprevalence of rubella IgG and Zika IgM across Ilorin, Kefi, and Mina. Now, this shows the trend of what we saw in these sites. In terms of with 188 respondents in Ilorin, we saw 17% of them presenting with Zika IgG, and then of course we had 63% of them presenting with rubella. That gives an indication of high level of transmission going on in these localities. Now, we went further to also juxtapose in terms of confirmation if serological investigations might be giving us false positivity. Now, molecularly, we did what we call optimization of primers, and primers optimization improved the RT-qPCR detection reliability. The CT values, of course, confirmed active infections. And what did we see? Now, the implication of all of these is the fact that the lineage diversity justifies whole genome surveillance for maternal fetal risks. Now, this is the result of the molecular confirmation for Zika. Now, what we observed is that for 4 samples which actually came positive serologically, we're able to carry out, this the return PCR analysis, and we saw that they had strong positive correlation. In fact, the CT values was showing less than 29, which of course shows strong positive correlation. And for all these samples that we also investigated for these return PCR, they all had strong positivity for Zika virus transmission within the locality. Now, what does it speak? It means all the 4 tested isolates fell between the CT values less than 29 across E, M, and NSI proteins, which are the proteins actually that depicts Zika, viral pathogens, and which are unambiguous for molecular confirmation of active Zika circulation in the cohort. Now, that takes us to dengue malaria co-infection. I haven't talked about Zika in febrile patients. Now, Our study also revealed that there are hidden behind the malaria diagnosis. In the Ilorin febrile cohort, 1 in 17 patients presenting with presumed malaria also carried active dengue. Now, our study was able to establish the fact that 5.81% actually had dengue malaria co-infections within the population. And the study also revealed, interestingly, among all the serotypes, then 2 serotypes, then 3 serotypes, then 4 serotypes were all reported in the cohorts. And these are serotypes that also have been reported in South American nations, Brazil and Mexico. And interestingly, then 2 serotypes, which is very, very serious, was actually having more prominence in terms of reports in these localities. Now, what was this implication of this? It means routine differential diagnostics must include arboviral screening along malaria themes. So people going to the hospital, febrile illness, complain of febrile illness, must not just be screened for malaria alone, they should also be screened for arboviral infections. Now, chikungunya, which is another arbovirus, we also reported seroprevalence and the risk predictors. Now, when neighborhoods carry the highest risks and why? Which neighborhood rather carry the highest risks and why? Now, we observe from our study that CHIKV, of course, 12% of the population were actually reporting positivity for CHIKV. Now, we also linked environmental and behavioral predictors to the positivity that was also reported in this cohort of 250 respondents. And what did we observe? Number 1, stagnant water near dwellings gave strong correlation to positivity with people who actually were the respondents and where they live, where they reported that they have stagnant water near their dwellings. 2, bush adjacent residential zones gave strong positive correlation also to CHIKV positivity. 3, absence of bed nets use was moderate from the study location. And then poor refuse management was also moderate in terms of positivity to CHIKV. And then finally, we saw interestingly that outdoor occupation exposure became an emerging risk predictor to CHIKV prevalence within the population. This speaks a lot of volume. By the time we carried out the IRR-based modeling, it points vectors control towards stagnant water, bush fringes, and households without bed nets. A targeted, affordable intervention map was designed in this perspective. Now, it takes me quickly to respiratory viruses in children less than 5 years. Our study also in this location also reported 85.5% positivity for IgM seropositivity. The study also reported 99.5% IgG seropositivity in that studied location also for RTIs. And interestingly, our study over the years, we have been able to contribute new genotypes confirmed for human respiratory syncytial virus B, BA9, and human adenovirus B and C, which have been deposited in the gene bank in NCBI USA. Now, what did you observe from these studies in terms of RTIs? What the data tells us is the fact that the 1 to 2 year age group is the peak budding window for surveillance. Now, RSV B and BA9, and of course, human adenovirus B and C genotypes were validated and deposited in the gene bank. Now, combined serology plus molecular genotyping is essential for accurate, attribution to these transmission mechanisms. And then, of course, we also observed, which is very pertinent, that seasonal and nationwide expansion is the prerequisite for policy-grade forecasting. Now, this study became a crust. The work of this study was published in Medical Virology, which was Blackwell. And of course, just this year, the Global Network for RSV Surveillance, which we also belong to, published the work globally now in Lancet in January this year. Now, the phylogenetics analysis, where Nigeria's strain sits now, and it's interesting to share with you where the Nigerian strain sits or where the African strain sits. Now, it sits as this for Zika virus. For the EM and the NSI proteins, which have been reported, we have been able to establish that it clusters with the 2015 Brazil lineage. The rubella virus E1 glycoprotein was observed that there was no wild type match in the 31 WHO reference strains. So it became a very new strain that actually was reported. Now, the human respiratory syncytial virus B, BA9, which of course is the G gene, shows a distinct Nigerian clade confirmed. And this was also reported and deposited in the gene bank. And then the human adenovirus, which is of course the exon gene, showing the human adenovirus B3 and human adenovirus C1 genotypes are currently co-circulating, not just within the locality, but of course, transmission mechanism, which shows indicators, shows that it's now moving in terms of transmission dynamics. Now, quickly to environmental intelligence, which plays out as a part of the three angles I shared with us earlier, the rivers, the wastewater, and the metagenomics as early warning sentinels. Ashikpa River, which is a major river that flows from Kwara also to Niger and of course other suburbs of the north central zones in Nigeria. We have conducted extensive studies in this in terms of enteric pathogens and interventions pilots. Now, our study also were able to establish that when the river becomes the reservoir, the laboratory bench becomes the first response. Why Ashikpa River? Our knowledge, attitude, and practice and behavior, physiochemical analysis, and microbiological analysis flagged Ashikpa as a priority sentinel site. And of course, the enteric pathogens and viral signatures were recovered with sequencing support. We went further to look at interventions, how we can be able to remediate this river in terms of reducing the pollution index. We tried a zinc oxide nanoparticle pilot study in terms of treatment analysis, and we're able to establish that total coliform load fell sharply by hour 3, and of course approached 0 by hour 6 across both sample sites for D3 and B3. Now, the proof of concept of this, of course, supports this low-cost, point source remediation in peri-urban, river system. Now, we also report also from the Asa River, which is also another major river that flows within the north central zones also. Heavy metals, which are heavily polluted, and of course, reporting cadmium in high concentration. And these metals, not just juxtaposing that, we also went further to look at the metagenomes in terms of the bacterial load capacity that are found in this river, and try to compare what happens and plays out if these bacteria that are found in these rivers are actually bacteria that have been noted also in clinical samples in patients which have been reported in the hospital settings. And what we observe is this: heavy metals plus coliforms, there was significant environmental pressure detected. Now, in terms of diverse bacteria and viral, community structure spans multiple taxonomic families. What are these families? We have reported adenovirus detected from this river, which also have been reported in hospital settings. We have reported also SARS-CoV-2, also detected through metagenomic study from the river. And of course, phage signals also. These viral signatures became trackable as epidemiological markers, particularly in terms of response to outbreak within the population in our hospitals also. Ecological intelligence, Asa River also viable as a wastewater surveillance sentinel, also give an indices that this is also one direction which we need to look into in terms of the three angles to infectious disease control and public health response. Now, we went further to look at what we can do in terms of best science for safer water, particularly for those in the rural community. And that took us to the point of looking for pathogens, particularly bacteria from Oyun, Agba, and Asa rivers, that's using bacteria to treat bacteria now, isolating microbial strains that clean water at community scale. Now, what did we do? The pipeline was very simple. We isolated these microbial strains from Oyun, Agba, and Asa river, went further to screen them for flocculating activities across the isolate in terms of their capacity to reduce the biological oxygen demand and the organic matters and the chemical oxygen demands that are found in these polluted rivers. We went further to optimize also these bacteria with cultural conditions that for yield and activity. We also went further to translate in terms of pilot testing on domestic wastewater to see the effectiveness. And the result was quite interesting. The flocculating activities in terms of across the culture groups of bacteria combined together gave high flocculating potentials of almost greater to 97% that was achieved with the highest group of bad flocculants. So this is one very interesting study, which of course gives a preference that we can begin to think about what we can do. Our next steps is to do dose optimization and testing across wastewater types now in terms of different wastewater, pharmaceutical waters, domestic wastewater, agricultural waters, and the likes. Now, what is the bridge? The bridge in this presentation has to do with our sensitization that we have shared patient, we have shared geography, and we have shared season. This is the moment that the three angles collapse into one. And what are these? Arboviral, respiratory, environment, they become one system. Now, the three overlaps that prove the point are as follows. First, the shared patients. We have been able to report that 5.81% in the study cohort of Ilorin febrile patients diagnosed as malaria were also carrying active dengue viral infection. In other words, it means one blood drawn from a patient, two pathogens mixed. It's either you do it correctly to get the two pathogens, or based on what we have seen with our limitations that I've explained earlier, we have often missed the second pathogen, which has to do with dengue. Now, the shared geography, one river, of course, passes through our locality and our environment. The same Aedes mosquito, of course, that transmits chikungunya, which have been reported with IgM seropositivity, is the same river, of course, that breeds this mosquito in the same stagnant water. We found coliforms, heavy metals, SARS-CoV-2, and adenoviral signals along Asa and Ashikpa River. Now, our shared season, of course, there's no doubt about this. The seasons remains constant. We always have rain season and we always have dry season. We have observed that between March to October, there was peak cadmium loading in Asa, which overlaps the peak vector breeding and respiratory virus season. One sampling window captures signal across all three domains. And what is this? If the pathogens share patients, geography, and season, then our recommendation from this presentation to every one of us is that the surveillance must share data, environment must speak to the clinic, and the clinic must speak to the environment. They must share samples, and they must share diagnostics. Now, the integrated workup that we have been able to propose is that one sample, many streams. We have seen that a single febrile patient workup pulls from clinical, laboratory, and environmental streams at once. We have the clinical, we have been able to establish the febrile history, which clinicians does, symptoms profile, IgM and IgG panels. We went further to the laboratory investigations, looking at the confirmation of molecular techniques of RT-qPCR, the sequencing capacity, and of course, the co-infection panel. And then, of course, juxtaposing these with environmental indices, looking at the sampling for the rivers, and of course, heavy metals overloads and metagenomics, where some pathogens are unculturables, metagenomics will pick those pathogens in the environment. Now, the shared metadata pipeline further substantiates that for one patient ID, there must be one timestamp and, of course, one geospatial anchor. Now, what will this do? If we promote this, it will enhance what we have been lagging for in the continent. Earlier, outbreak detection will be more promoted as we prepare for the next pandemic. 2, accurate differential diagnosis to save the lives of our people, particularly that goes into the hospital and they say no malaria and they go back home celebrating, not knowing that, of course, they could be infected with dengue. 3, targeted vector and water actions. The need to promote sanitations in our environment because prevention, as we know, is better than cure. Now, the bridge is not just a metaphor. It is a shared sample identifier, a shared database, and a shared decisions between the clinicians, the environmentalists, and laboratorians. Now, our ongoing research from my group, we have gone into the process of, making AI to meet virology. And what are we proposing? The next frontier is now using machine learning to accelerate detection, dosage, and mutation tracking. We have started in this direction. Currently, one of the master students is working on Lassa surveillance model. is currently looking at integrating demographic data, seroprevalence, and molecular signals to forecast Lassa fever outbreak risk across Nigerian states. We are also proposing, we have been able to develop an AI bioflocculant calculator app, which has been patented by the federal government of Nigeria from my group in my lab. Now, we are proposing that a mobile workflow that computes flocculating activity on the fly and recommends fit dosage for community scale wastewater treatment should be urgently implemented and piloted. 3, we are also looking into the point of genomic intelligence, now chikungunya mutation tracker, comparing Nigerian chick-V protein sequences against global reference sets to surface mutation, hotspots, and vaccine-relevant divergence. All these 3 angles of approach, we feel with these, we'll be able to meet the needs in the continent. Now, each track links directly to the surveillance loop, closing the gap between the discovery and the deployment. Our recommendations is very simple and straightforward for every audience as we leave after this Researchers Forum seminar today, is that the architecture is the bridge. There must be a bridge, and we must come to that point now. And what is that bridge? Each capability is a pillar. Together, every one of us, they are the bridge. And the bridge now, number 1, is the multiplex serology. Currently, my team and my lab, we are currently working on multiplex serology now in terms of one blood drawn, many pathogens screened at the same time. We have a panel now through the multiplex serology with 9 African countries in this collaboration and sponsored, funded by Wellcome Trust. We are looking at almost 30 panels of pathogens that can be investigated at once using the Luminex sequence, Luminex multiplex, apparatus machines to carry out this investigation. 2, the second recommendation is RT-PCR diagnostic. Decentralizing, there's a need to decentralize molecular testing in regional laboratories so that there should be a link, there should be a regional bridge such that pathogens that moves easily, we should also be able to move easily with our research capacity within the continent. 3, whole genome sequencing, lineage tracking, strain diversity, vaccines match monitoring. These are areas that we need to begin to look into as we plan for the future pandemic in our public health response. And then 4, the settling water monitoring system, rivers and wastewater as early warning sensors for human disease. These are areas of research that I also want to promote that we should begin to think about also in the continent. And then the last but not the least is geospatial risk modeling. An AI-assisted hotspot mapping on standardized metadata is also critical at this point for us. Now, having said all of this, there's shared metadata, there's shared samples, IDs, there's shared decision-making, and then what should be the call to action? My call to action in this presentation is that the Nigerian Center for Disease Control and other centers for disease control within the African continent, WHO, Afro, and AAU universities should form the 5 pillars together, not separately, because the environment must speak to the lab must speak to the clinic. The value comes from integration, not from any single capability in isolation. There are several research publications that have been published from all these studies from the group, and we can see many of them from, that have been published over the years, that these studies have been conducted. I want to specially acknowledge the following. The evidence in this talk is the work of a team. My gratitude to every active. They have completed their program now. They're doing well in their universities. Dr. Suleiman Mohamed Mustafa, he carried out the study on rubella and Zika in women of childbearing age. Oyekunle Omotayo Abdullahi carried out the chikungunya prevalence and RI predictors. Associate Professor Idris Olayinka Oluwatoyin carried out respiratory viruses in children under 5 during a PhD under my supervision. Adeyemi Oluwasomi Oluwasukomi has worked assiduously on Ashikpa River surveillance and metagenomic investigations. And Seriki Adebimpe Adetona, Adetola also carried out the dengue malaria co-infections in febrile patients in Ilorin. and of course the North Central states. Now, I want to specially with gratitude to the Association of African Universities for convening this researchers forum and to every colleague advancing public health resilience across the continents. Especially the evidence in this talk is the support of institutions, partners, and collaborators. My gratitude, of course, again to AAU, and of course, more importantly, to my university, the University of Ilorin in Nigeria. And of course, I want to especially thank all my group, Infectious and Environmental Health Research Group based at the University of Ilorin. Also, special thanks to all those who have supported our funding, our research in the past, TED Fund, Bill and Melinda Gates, and of course, Wellcome Trust, and of course, my collaborators in Warwick University at the United Kingdom, and New York University in the US. Yes, these are some of my students in action with me. And of course, as a conclusion, an integrated human environmental surveillance model. I want to conclude to say that combining need for virology, environmental microbiology, and innovation to generate actionable evidence for early outbreak detection, safer water treatment, and stronger public health decision-making across Africa and comparable settings. On this note, I want to say thank you, and then, of course, you can scan and let's connect. Thank you, and over from my hand.
Thank you very much, Prof, for this very, very brilliant and exceptional presentation. And indeed, it's timely. We have one question here from Professor Bridget Tibois. And she says that she caught something that she said earlier, which is that most febrile children are treated by default as malaria. And that is a very common practice in Cameroon and also in fresh doctors. Thank you very much. And over to you, Prof.
Yeah.
Okay. Yeah, Prof, you can speak.
Okay, please go ahead. Please go ahead. If you want to ask the question, please go ahead.
No, I'm actually right here, and I thank you, Lydia, for asking that question on my behalf. I just want to commend you on this really brilliant presentation, and it's interesting because I asked if it is due to lack of training, and I see that you do a fantastic job, not only with your students, but with other institutions that you work with. And so I'm concerned, why is this persistent need to continue treating not only children, but everybody as a malaria patient when they go to the hospital? And that is where the neglect, in my mind, comes from. Because you walk into the hospital, especially in Cameroon and other African countries. I don't know whether people don't want to do their job or what is the problem. What did you find out, or what have you been able to find out? And I'm from the University of Massachusetts in Dartmouth, USA. Thank you.
Thank you very much, Prof. Thank you. Great question there. Great question. I'm happy you are passionate about Africa moving forward. Sincerely, you have just, yeah, I know. You have just said it all. Yes, sometimes we talk about lackadaisical attitude of our healthcare workers. That's one thing we cannot push away from that. But of course, the infrastructure also, and the infrastructures there. From my presentation, you could observe that we went further to do, even patients that are said to be febrile, that they were not actually presenting with malaria. We discovered dengue and tick virus because we went further for investigations. If you look at our hospital settings, aside the tertiary health centers, okay, Prof, most of the rural hospitals don't have molecular, laboratories for investigations to further carry out when they do malaria, surveillance. And this is one critical area that I feel that from this presentation and through this AAU, researchers forum, we need to begin to speak in this direction. That our government should fund primary health centers with molecular equipment. Because it is not just enough to say patients go to the hospital and after they are tested for malaria and they said malaria is free and then you go away. You see, most of these things we have been able to observe is the fact that there is lack of infrastructures, and infrastructures, even when they are there, people are not properly well trained. Those who are supposed to man the infrastructures are not well trained too. So capacity building is quite critical. Institutional capacity building, and of course, not just that alone, even individual capacity buildings as public health professionals. One of the things is what AAU is promoting now through the Researchers Forum. This is a very great channel for capacity building for every one of us. even that we are here. I mean, we have a role to play in this regard. We are doing better in our institution. That does not speak enough. The continent must feel our impact. And that's the basic of why we are researchers. Enough of our work just remaining in the laboratory. The lab must speak to the environment must speak to the clinics. Enough of clinical isolates or silos of research, enough of laboratory silos of research. If we want to move in the continent to work against the next pandemic, preparing for the pandemic, there's a need for synergy in these three angles, which we have been promoting over the years in my group. Thank you, Prof.
Thank you. Thank you so much. Absolutely. You can tell I'm as passionate as you are, because my mother is from the Cameroons, and she is a retired midwife and nurse. Incidentally, she trained in the Ilorin School of Midwifery in I think 1952 or one of those years. And so I've been looking forward to getting to Ilorin to find that old school, but they told me it has merged with the university, because I'm writing a book on her right now, and it's called The Life and Times of Madame Maternity. Maternity as in the delivery ward, and all the challenges that I saw her go through as she tried to provide healthcare and interdisciplinary studies. I'm a trained historian, but women's studies and Black studies, they all intersect. And this is a subject that is dear to my heart. So thank you. Thank you all so much. I appreciate it. Thank you.
Thank you. Thank you.
Thank you very much, Prof. So we have another hand up. So Mr. Muftau Mushood, you can unmute and then come out with your question. Thank you.
Hi, can you hear me?
Yeah, we can do. Thanks. Please go ahead, please.
Yeah, well done, Prof. It's good to see your face. I'm Muftau Adeni, one of your students. After 11 years, I'm happy I'm happy to see your face and learn again. I'm now in Brazil doing my master's, food microbiology. But because of your long-term work inspiration, so I've been taking a lot of interest in following a lot of medical work. And when you were talking about treating by default, I was not the only person that was shocked. As every other person in this presentation. So my major concern now, due to what you have taught majority of us in the past, how sure are we that we don't even have many strains of this dengue circulating now? That is my first concern. What I want to ask, that as the work that you are doing now, the leading team, and particularly because of what other people have learned today, in order to help generally, if the people at healthcare setting, maybe because of a lot of reasons that I know it may be peculiar to different countries, if they have been finding it difficult to do their work, which will not be deliberate, I think, because of some other factors, which other thing do you think we can do in terms of people now? Because, for example, in Brazil, when I started my master's, one of the things that they are very particular about in terms of dengue, they are not even talking about malaria now. You will just, when the season comes, because from what you've already said, the season also supports the breeding of the dengue. So now they don't talk about malaria. They sent a direct message to everybody throughout the country as a means of sensitization that this is now a season for co-infection, particularly dengue. So which means as citizen, when you wake up and you just feel like maybe you are already been sensitized that it is not about malaria sometimes. It may be dengue. It may be another thing. So generally now in Africa, what do you think, as your work and other people on this platform, what do you think can be a direct link between the laboratory, the researchers, that they know what might be going on directly to people? As a way of saying, okay, when I go to hospital and I say, okay, this is what I'm feeling, and even for one or two reasons, the people that want to do the diagnosis, they may not want to treat you for, they may not want to test you for every other thing. But you yourself, you've already prepared your mind that it may be another thing. So what do you think we can do in order to bring general people on board, in order to be sensitized and know that you may not be having only this, you may be having another thing? And lastly, I want to appreciate everybody for bringing this platform, and in order to continue to sensitize everybody throughout the Africa about not only this, but every other disease. So thank you again. That's my comment and question. Good to see you, Prof.
Thank you very much. Thank you. It's good to see you again. Happy to see my students doing very well. That's a great one. Thank you for connecting all the way from Brazil. Your question is very timely, and I think this is one area that every one of us have a lot of responsibilities to do. No one will solve our problem for us in Africa. Absolutely no one outside Africa will solve Africa's problem for Africans. We will solve our problem ourselves. We will tell ourselves the truth. We will do the needful ourselves. We have the role, we have the responsibility to do this. And what are the responsibilities? First, as researchers, I'm playing my part. And the part I play is the fact that I do the work and I make sure when the work is out, I published it. And when I published it, I sent it to all the stakeholders in Nigeria. I recall, I give an example. Now, there was a collaboration I had with New York University with collaborator in the US. That was in 2017 on RTIs. And then we conducted that study in Nigeria. And then I reported coronavirus, OC/NL63, 2017. We reported coronavirus. Now take note of this. At that time, this work was published. I shared it with us. It's there, one of the papers there. It was published in BMC Research Notes. And my collaborator in the New York University was celebrating. I did work in Africa, you are celebrating there. So it's interesting to me. But at that point, what I did was to circulate it to the government, circulate to the health institution in the country, Nigeria. That it made no meaning to them at that time because nobody was thinking about corona in 2017. It was no meaning to the health officials at that time. So you play your part as researchers too. That's what I want to, I want to sensitize every one of us to do. Now, that thing's ran a lot of bell. It was kept there. But when COVID came in 2020, I had my inaugural lecture in 2020, in January 23 at the University of Ilorin. At that point, COVID came to Africa, visiting us after coming from China in 2020 in February. Do you know that it was that published work which was circulated was what the Federal Ministry of Health saw and invited me to join the Ministerial Expert Advisory Committee to support Nigerian government in handling the COVID pandemic during the COVID era in 2020. Now, something happened in 2017, which I circulated, and the effect was felt in 2020. Please, whatever work you are doing as researchers, do it very well. Make sure it's published. I'm happy we have Taylor and Francis here, which you have brought to also join us. Afrobarometers, they are all here. They are ready to give us all the support. Let's make sure we publish all these things out. By the time it goes out, of course, we now begin to speak to our publication in anywhere we go to. Secondly, private-public partnership is also crucial, particularly in terms of infrastructures. I talked about, Professor Tebo just talked about the fact that sometimes we miss this also, like in Cameroon. Most of the rural settings don't have molecular equipment, but we have private organizations, companies that are multi-billion investments, which they can invest into these areas. What are they doing with their funding? They can invest. So we need to promote private-public partnership. They can invest little small labs in those little communities, such that when you go for malaria and they say it's not malaria, immediately they test you for dengue or test you for chikungunya because they have molecular equipment also available in the hospital. So the government might not be able to do this alone, of course, as we know in Africa, but there's a need for every one of us as these private investors to key into this approach also. So this is just my own suggestion, and I feel with this direction, we can be able to make forward. Finally, all practitioners, health practitioners, environment must begin to be friends. We must speak one language. It is no longer, this is my profession. We are all looking towards the health of our people. The environment must speak to the lab must speak to the clinics must speak to the environment, the laboratory also must speak to the environment. In that way, as I presented in this presentation, the three angles will work for us, particularly in Africa, as we navigate these very, very tremendous times of infectious disease transmission within the continent. Thank you very much. I hope I've answered your question. Thank you, Lydia.
Thank you very much, Prof, for this very splendid response. There's another hand up here. Victor, you can unmute and ask Prof your question. Once you are done, I have one question I'd ask Prof, and then Kamal would come in.
Yeah, thank you very much. Good afternoon. Yeah, good day, Prof. It's a pleasure to hear you speak. Most times, upcoming scholars like us, when we hear our mentors from the distance, it gives us hope that there's hope for Africa. Having said that, the truth be said, you've spoken well, Prof. But the problem, I'm a medical sociologist, which over the years, for some 2 years now, 3 years now, I've ventured into One Health research. And that really opened my eyes into research. Because if you know, in Nigeria, medical sociology, we are very few in number, and venturing into One Health, which is all encompassing, gives a new dimension of research, especially in public health. And in that, I discover a lot. That Africa, there's a book written by an African, say How Africa Underdeveloped Africa. The truth being told, we as Africans, we are the one causing even most of our problems by ourselves. Why do I say so? For instance, funders, Europeans will give grants for Africans to solve our own problem. Now, instead of us to make sure that we judiciously use those funds, to do those research, but rather we tend to look at our own self-interest rather than the research and the outcome of those research. And also, now the data, like you said, very few researchers do translational research like you did. Very few. A lot of researchers who have funded projects, when they get those results, they are not outside there. I'm more of an ethnographer. I think for the past 9 years, I do more of ethnography. I live with people, I know what they do, tend to look at the social determinants of health. Now, you go to field, you see this problem. Now, you are bringing back to bring out as the findings. Now, you are telling, because I just finished, unfortunately, I just finished a postdoc, which was paused, which was regrettably stopped because of misappropriation of funds in Nigeria here. Now, you go to field, you find out data. Now, you are telling your PI here in Nigeria, this is what you think should be done. Now, you've gathered a result. Let's go back to the community and translate this result to the community in order to give awareness to the people. But the reverse is the case. What you find out that, imagine a PI will tell you, you want to spoil my work for me, you want to spoil my work for me. So it's, as an upcoming researcher, it gets us crazy. It makes us to just crazy, yeah. So sorry to use that word. And you being in field, you are seeing what these people are facing. Recently, we did a work on Lassa, on One Health. Unfortunately, I was infected with respiratory tract infection in the field because I work in an endemic area where you talk to the people, you live with them, you eat their food. And unfortunately, I was infected, but thank God I was okay. Now you are suggesting to somebody, to a PI, this is what you think should be done in order to improve the health of the people, even if as you are working, nothing is being done. So in this context, because not all researchers are research-minded like you, who have the people at heart. So when you find yourself in a such situation, now, what will you do? That is one. Secondly, now we have a lot of ideas when it comes to social determinants of health and trying to incorporate both the under One Health, like you said. Now, you have ideas. There is no funding. Now, even when you even write, you don't even have those funding. Now, if at the end of the day, you have such, maybe you do some personal fund to do some research, and you know to publish papers now is very expensive. We are talking of the list of $2,000 or pounds. Now, for an upcoming researcher who is still struggling with himself, you find out that we find it very difficult to publish good research that is being done because of lack of funds. Now, in this aspect, especially in the developing country like us, now for people like us, what do we do in issues like this? And lastly, you made mention of dengue. Myself with some group of scientists and virologists, because I work with some scientists. So we brainstorm and find out that within the South region, this issue of Lassa, because there's what we call political economy of health. Now, some states or some stakeholders will decide to hold some of this data not to spread out. Now, and in the long run, is affecting the people. And there's also a transmission, first and second and third transmission of disease within circulation, which is very, very dangerous within the system. Now, we now find out that, okay, now, let's go to the South because with this dengue, the dengue, Zika, and chikungunya, we find out that the Egyptian, what is it called, Aedes mosquito who transmitted is more common in our region here. So we now said, okay, let's see what we can do in order to carry out a preliminary surveillance sample. Now, as we are talking now, just a group of us, I want to do this.
Hi, Mr. Victor. Could you kindly wrap up on the question so that Prof can
I want
quickly
to wrap
come
up.
in?
So, in situation like this, as an experienced scholar, now what do you advise some of us who have this love and flair for public health to make sure that the society is free from endemic outbreak? Thank you.
Thank you very much, Mr. Victor. I think your question, just in one word, if I want to answer it and make it clear a bit, is the fact that you need to, there's something we call integrity in research. And I would like to also let you understand that you can't be a researcher if you don't have integrity. Because we need to understand the fact that our data are not just data as you see them. They are data that as you see them, they are also live. And the moment you hoard information, then you have not done anything meaningful as a researcher. So please don't allow anybody to intimidate you in terms of data release. If you find information, don't change them. That's what Africa should be. We should be the leading light. We should make sure that what should be done should be done. The other one I just want to encourage you on is that, yes, as an upcoming early career researcher, please don't give up. We were in your shoes. So we were also in Africa. I trained in Africa, my first degree, my master's degree, and my PhD, all done in Africa. So, we never gave up. So whatever it is, all you just need to do is to make sure that you develop yourself, more importantly. Find a way to develop yourself. Move with the train of what is going on. I've shared a lot with you here in this presentation. And I believe that there are certain areas that I feel you should have looked at what you can key into that you want to further with your own career research. A lot of exposure has been given here in terms of interface of linking the environment with public health, and particularly that it's no longer silo research. Silo research doesn't speak any longer, and it's not going to be good for us in Africa if we go on silo research. I look forward to collaborate with you even in medical sociology where you are. You are relevant in terms of looking at the social context of how people actually feel when certain things are actually given to them in terms of clinical trials. So I'm sure I'll be able to provide some answers to this. But of course, you can contact me from the contact and then we can discuss further after this seminar. Thank you.
Great. Thank you very much, Prof. It's really great to have you join this Researchers Forum. And I believe that a lot of early career researchers would really benefit from this session. Now, I was very happy when you mentioned that as Africans, it's very important that we identify our own problems and then we solve our own problems, because nobody is going to solve our problems for us. And listening keenly to your presentation, this is a research work that has a very great potential to solve some of our key developmental issues here in Africa. So what I want to find out is that, looking at your work more broadly, what kind of opportunities, support, what kind of opportunities would be most critical for you in terms of advancing your research into a large-scale implementation? Because I believe research shouldn't just end when the research ends. That it has to be implemented. So what kind of support opportunities would you need to upscale this great initiative?
Thank you, Lydia. Thank you. That's brilliant. Great question. And I'm happy if they're asking that. And I look forward to that support, We need funding. Yeah, funding. I shared with you the acknowledgement of some of the partners who have funded my research and my group for over the years. But of course, we still need funding. Just recently, I've been able to, bring in a PhD student via a funding, full scholarship at the University of Ilorin with the Wellcome Trust funding. I mean, throughout the 3 years, you'll be working on virus, modeling approach in Nigeria context. And this was funded by Wellcome Trust in collaboration with Imperial College. So you can imagine. So if I have more funding, I can take more PhDs, I can take more postdoc. And these are the areas which they can do more intensive research, showing some of the things the areas of concern that I really want to go into. And I just itemized, one of the areas is what one of the PhD students have just started now through the Wellcome Trust funding, which we just got, being supported. And of course, the enabling environment provided by the university also is very critical. I want to commend my university, University of Ilorin, my Vice Chancellor. They provided an enabling environment. When I got the Wellcome Trust funding, they provided an enabling lab space for me at the Central Research Lab, dedicated for my group. So, and of course, the university also have even supported providing, alternative light supply, which has to do with solar. You know what I'm talking about now. So that some of this equipment, when they are running, they don't stop that way. So we need institutional support from the university, which my Vice Chancellor has provided in that regard to make sure my lab runs. Aside that, we need external support. And this is where I think AAU, the Association of African Universities, please should come in to support many of us who have drive and initiative. We are doing a lot of stuff in Africa, and they want us. I mean, just last week, I got a mail from somebody from the United States, a private company who wants to carry out a clinical trial with me, testing his diagnostic kits. And I asked him a question: how did you get to know about me? He said he only Googled. You Googled from the US, and you just Googled and said, give me somebody in this space in Nigeria, and my name pumped up. And that's all. That's how we started communicating now. And I mean, if we have people, private organizations, industries who can build capacity in research, support government for funding, we don't need external funding much times. We can generate this funding. And I'm sure the Association of African Universities also will be able to come to some of us to support us with more funding, to take in more PhD. And of course, I'll be happy to have postdocs also in my group to work in all those areas that I've itemized. Thank you so much.
Thank you very much, Prof. Once again. This is actually a priority for us here at the Association of African Universities. We really hope that African researchers would not just remain in our libraries, would upscale it. And as you have rightly said, there's a need to fund these researchers. So, Prof, this is very well noted. This would be pushed to the leadership of the Association of African Universities, and we would get in touch. So at this point, I would hand over to Kamal from Afrobarometer, share a few words, and then we can wrap up today's session. Thank you very much. Kamal, if you are here with us, please unmute.
Yes, thank you so much, Lydia, and thank you so much, Prof. Olatunji. I must say, it's not always that you meet, African academics who are, really passionate about their work. So it was very good and refreshing to see. I'll take this opportunity to share some of our data again, especially given the discussion of medical sociology and bringing in the social context into the study of health in Africa. So once again, I'll focus more on the variable itself this time, but I'm looking at a variable from Nigeria, round 10, which is our latest round, and I'll select and analyze. And given that we're talking about health, we had a question on vaccine hesitancy. This is an area that I'm interested in myself. So you can also, instead of going through the whole index of questions, which is the manual way, you can also just, with all apps and APIs, just search for child. And I know that the question was, this is a question that we asked on vaccine hesitancy in Africa. Yes, hopefully you can see my screen. Let me zoom in properly.
Yeah.
So we asked this question. It's a, forced choice question. Respondents are, forced to indicate whether, they agree with option A, B, or C. So which of the following statements is closest to your view? Choose statement 1 or statement 2. Statement 1, in order to protect children in the community, parents should be required to have their children vaccinated against infectious diseases such as measles and polio. Statement 2, having your child vaccinated against infectious diseases is a parent's personal choice and should not be mandatory. And if you look at, the responses, just in terms of frequencies, you can see that, in terms of the representative sample that we got from Nigeria, about 82% of respondents said vaccination should be mandatory, and, about 20% said that vaccination should be a personal choice. So the ODA allows you to look at the data in tabular form, in terms of raw frequencies. You can also toggle between different charts, but most importantly, you can also select what we call a crossing variable. So we have demographics, for example. So you can, for example, let's see whether there's differences in gender between respondents, right? So I'll choose the gender variable, respondent's gender, right? I hope you can see my screen.
I do, thanks.
Respondent's gender. Let's see, gender. So respondent's gender is question 101. So I apply that. And now we have the ODA so we have the table that gives you the responses, but broken down in gender form. And in this case, you can see that in terms of gender, there's really basically no difference between the respondents of men and women. You can also change the variable. So for example, if I change the variable to it's nice. We have an urban or rural sampling unit. Sometimes, the rural areas have, maybe more beliefs in non-scientific causes of illness, etc. And in the rural areas, interestingly, it's, personal choice is lower than in the urban areas. So this is just to say that, especially for the questions about, grounding public health within the social context, I think that, once you have demographic data and, like the two researchers have shown us that, the first researcher collected data on clinical health workers, Dr. Olatunji has, gone into, epidemiology and disease structure. So I think that Afrobarometer allows us to actually also bring the voice of the citizen into your analysis, whether it's public health, whether it's agric, whether it's climate change, so that at least your research can be easily translated for the policymakers. Thank you, Lydia. I would like to stop here.
Thank you very much, Kamal, and thank you once again for joining us, Prof. Kolawole. It really has been an honor having you on this forum today. Thanks a lot. And we are concluding today's session. However, perhaps it would be useful for researchers focusing on research in climate and health to note that currently AAU has rolled out a call for proposal for researchers at the intersection of health and climate. So if you are a researcher in that field, kindly visit the AAU website, or even better still, visit our grants website. We would post it in the chat box. It's grants.chinova.aau.org. So you can visit the website, look at the eligibility criteria and see if you meet the criteria, and then you can put in a request. We are awarding up to $200,000 US dollars for that call. So it's just something that I thought to put out there so that researchers in that field can apply. And thank you all once again for your participation in today's session. We've had some really, really enriching discussions. So let's keep this momentum up, especially in terms of connecting, in terms of keeping our collaborations. And for those of you who would want these recordings, kindly visit the AAU YouTube and Facebook channels via Association of African Universities. But we'll be sharing some series of emails, and in those emails, we would also attach the link of the recording so that you can easily access it. Thank you very much to you, Kamal of Afrobarometer, for your continued support and your guidance. And thank you so much to you, Prof. Kolawole and Dr. Charles, for sharing your inspiring research with us. Now, before our next session, as I mentioned, a call for presenters will be shared via email. So anybody who is interested in presenting is encouraged to fill out the form and also express your interest Our next edition is on 8th of May 2026. So please do mark your calendars. Thank you all very much for joining us. And we really take note of the comments that were posted in the chat box regarding creating a WhatsApp platform. So we would create that platform and share the link via email so that interested individuals can join the WhatsApp page. Thanks once again. My name is Lydia Nyame, and until the next forum, this is it. Thank you all. Bye.